I'm going to start off with a little bit of slide here. So as you know, I'm from Kansas City, and I really didn't dress up today, so I'm going to give the rest of my talk. There we go, Mahomes. So it's been 50 years in the making since Kansas City went to the Super Bowl, and we're pretty excited in Kansas City. The parade is actually today in Kansas City. They canceled all the schools, so all the kids are out of school. They're expecting over 1 million people in downtown Kansas City. It's supposed to be 6 degrees, snowing, but we're pretty excited about it. So as I've talked to a few other people, I think a lot of other people are pretty excited about it as well, whether that's because you're a fan of Andy Reid, who I think deserved to win a Super Bowl, or a fan of Mahomes, who's just an incredible young man. It's been a lot of fun. So let me move on. So I don't have any disclosures related to this project, and the funding for this sort of pilot trial was provided by departmental funds. My talks, I'm going to give obviously 5 talks, and 3 of my talks are really going to focus on how we improve outcomes related to cystectomy. So this is just one of the things that we've sort of thought about, sort of a little bit of a pilot hypothesis generating data, but you're going to see common themes throughout my talk. So you'll see me sort of flip back and forth between all these different things I'm going to speak about. So what's the problem? What's the problem with cystectomy? So I think anybody that does cystectomy knows that you can do a technically successful surgery, and yet the patient does terribly post-operatively. I cannot tell you the number of times that I've come out and talked to a family and said, it went great, really well, we lost very little blood, everything went really smoothly, and they're in the hospital for a week with an ileus, or they come back 2 weeks post-op with urosepsis. And so it's just a really troubling surgery, and it's a really troubling patient population. So I like to joke, and really don't joke, with a lot of my residents that I honestly go to sleep at night dreaming or trying to think of ways we can decrease the morbidity associated with cystectomy. So here's a typical vignette, and actually this happened to me yesterday on the way to the airport. So had a patient, he had CT2 bladder cancer, but you can imagine it's that or greater. Standard of care was followed. He was referred to medical oncology. He received 2 cycles of MVAC, and then the medical oncologist said, hey, by the way, I'm sending him back to you. He's not fit for any other chemotherapy. And my quip was, oh, great, well, he'll be ready for a cystectomy then. I mean, how many times have we gotten that call, right? Oh, I can't give him any more chemo, but let's get a cystectomy on this guy. So that's really, though, a very common scenario that we see. And so, again, what I've tried to do, and you'll see throughout these talks, is I've tried to look for ways we can modify that outcome and improve those patient outcomes. So, as I mentioned, the gold standard for bladder cancer, muscle-invasive bladder cancer, is neoadjuvant chemotherapy followed by radical cystectomy. But we know that it's associated with high morbidity. Morbidity rates, complication rates, usually around 40 to 60%. 1 in 4 patients that's been reported gets readmitted to the hospital, and then goes to the ICU. So these are very, very sick patients. And we still see 90-day mortality rates as high as 7%. Fortunately, perioperative mortality is extremely low, but when you start stretching that out to 3 months, you still see a significant amount of mortality in these patients. One of the major problems that you will see, and I tell all of my patients this, is significant amounts of weight loss. And that weight loss is really, and of course you tell them that and they say, oh great, I need to lose some weight. Well, it's not good weight, right? It's muscle loss, or cachexia. And there's a lot of work around cachexia, and we still don't completely understand the mechanisms associated with cachexia. And just to sort of define cachexia, it's the loss of muscle without the loss of fat. So really they're losing what we want and not losing what we would rather have them lose, which is the fat. And it's up to 65% of our patients in our series, looking at our own data, 65% of our patients developed either pre-cachexia or cachexia. And we know that that can happen even in patients who don't have any preoperative nutritional deficiency. So clearly those people come in and they look already very weak, they already look cachectic, but this occurs in patients who look really pretty good coming in as well. We also know that weight loss at cachexia is associated with poor outcomes associated with cystectomy, and again, I'll show some of that data later on. So one of the things we thought about was, well, what are some of the mechanisms that could contribute to cachexia, and could low testosterone, particularly in men, or hypogonadism, be one of those mechanisms? And so we actually kind of just checked, every once in a while I would sort of just check a testosterone, and I was like, wow, sometimes these guys would be castrate. So we wanted to sort of identify what is the prevalence of hypogonadism in these patients. There are prior studies suggesting that patients who have cancer or patients who undergo major surgery or anesthesia can develop hypogonadism, but there was no existing data for radical cystectomy. We also know that that can go along with trauma as well, and that's probably been the best literature so far, is looking at trauma and burn patients and what happens to their testosterone levels. But again, we really didn't have any data in the bladder cancer literature. But we know those patients, the male population, is at risk for those, for hypogonadism. So, we thought that it was very important to identify what that was in these patients. So again, we set out for the objectives of this study to determine the prevalence of hypogonadism in men undergoing radical cystectomy for bladder cancer. We wanted to look at the time period around hypogonadism, and then we wanted to sort of see what was that degree and how did that degree change over time. As I mentioned, this had never been previously studied, and there were no historical comparisons in the radical cystectomy literature. So we implemented a prospective IRB approved trial. We aimed to enroll 25 patients. We opened this study in March of 2017 and finished accrual in March of 2018. Seems like a long period of time. We're clearly doing more than 25 cystectomies in that time period, but you'll see some of the trouble that we had with the study goes along with just sort of the intensiveness of accumulating the labs, and that's why we had a kind of a long period of recruitment. This is just the clinicaltrials.gov page that showed the trial. So here are the labs that we collected at baseline. So we got perioperative testosterone, total testosterone, free testosterone. LH levels were obtained in all men, and that was at baseline. And then these labs were repeated at postoperative day 2, 3, 30, and 90. We defined normal testosterone, and of course this is very controversial. I'm sure I'll hear about this later, but we defined it, as does the AUA, with a testosterone level greater than 300, and that was based on the guidelines. We also recorded demographic data and perioperative complication data for the patients as well. Again, as I mentioned, we use the AUA guideline definition for total testosterone less than 300 as our definition of hypogonadism. And again, I think that could be debated, but as I show you some of the data, regardless of how you're going to define it, we're going to see a pretty significant results. So again, here's the trial design. Patients had to be eligible for radical cystectomy, and they had a baseline labs, and then we got labs at 2, 3, 30, and 90 days after radical cystectomy. We had complete data on 23 of 24 men. One patient who was enrolled in the study withdrew, and 2 men did not have all of the labs drawn, even at baseline. Mean age of the trial participants was 68 years, and all men were hormone naive. So they could not have had a prior history of hormonal therapy, testosterone use, or any other condition that could have caused hypogonadism. So we excluded any of those men. 9 of the 23 men received neoadjuvant chemotherapy, and I think you're going to find this data pretty interesting associated with neoadjuvant chemotherapy, although I'll explain, again, this is just a prospective trial, not randomized, and so that presents a little bit of a difficulty. Here are the demographics. I won't go over these too much. A couple of highlights. The average age of men was usually 65 to 69 years old. I already showed you that. They were overwhelmingly white, as you might expect in this type of population, and certainly in Kansas. They were relatively evenly split between preoperative neoadjuvant chemotherapy and not. No other really factors sort of jump out in terms of their preoperative demographics. So our mean preoperative testosterone was 308, the range being 50 to 566. We found that at baseline, so prior to radical cystectomy, a full 12 or 50% of our patients were already hypogonadal. 3 patients in that baseline demographic had abnormal LHs as well, which was the attributable cause of their hypogonadism. When we looked at this broken down by neoadjuvant chemotherapy, there was no difference. I thought that was pretty interesting. I really thought I was going to see that neoadjuvant chemotherapy cause these patients to be hypogonadal. Now, here's the caveat. I would submit that this is probably a selection bias because your younger, healthier patients are more likely to get neoadjuvant chemotherapy, probably also less likely to be hypogonadal, and your older, sicker patients, the ones that are probably more likely to be hypogonadal, were not as likely to get neoadjuvant chemotherapy. So probably a selection bias here, again, not a randomized trial, but here, again, as I mentioned the results, no difference between those who received neoadjuvant chemotherapy versus those who did not. When we started looking at post-operative testosterones, our mean post-operative testosterone on day 2 after radical cystectomy was 166, with the range being 32 to 345. So pretty dramatic fall in the testosterone immediately post-operatively. And then if you break that down, so 95% of our patients became hypogonadal. Only 1 patient had a testosterone greater than 300, and only 4 patients had a testosterone greater than 200. So all the others were testosterones, again, less than 200. 7 men, or 30% of the population, who were eugonadal preoperatively migrated into the hypogonadal population post-operatively. When we looked at postoperative day number 3, we saw a slight continued decline. Testosterone now was 161. You can see the range below. We did have a little bit of trouble getting some of these labs, and that really was just because this was sort of a pilot trial, and making sure that these labs always got drawn on these patients was somewhat challenging, and that became more true at day 30 and day 90 as well, making this a little bit challenging for us. So what about as we start to follow these patients out? Well, even at day 30, 83% of our patients still were hypogonadal. The range of the testosterone was 40 to 518, with the mean postoperative testosterone of 253. That's at day 30, a month after the procedure. 63% of our patients remained hypogonadal, and again, 9 patients, so 9 out of the 25, had testosterones less than 200. There was no significant difference in the incidence of hypogonadism, again, even at this point, whether the patient got neoadjuvant chemotherapy versus they didn't. So again, we thought, well, maybe those who got neoadjuvant chemotherapy and were hypogonadal might take a longer time to recover, but we did not see that. And again, maybe a selection bias. When we look at up to day 90, we had 70% of their patients that had their labs drawn. So again, we had some challenges getting those labs drawn. Our mean postoperative testosterone now was 306, but still a full third, or a little over a third, of our patients remained hypogonadal, although only 2 of our patients now were less than 200. And this is just sort of a table representing the testosterone levels, and you can see those over time, and I've already sort of mentioned this with just a summary of that. So as you would expect, hypogonadism did get better over time, but still remained as high as 37% at day 90 afterwards. This is probably the most striking slide, I think, in this presentation, and this is just tracking the levels graphically. If you look here, still a significant number of patients were below 300. This is at baseline, but look at the incredible drop over postoperative day 2 and 3, and then recovery of many of these patients day 90. But here, even a level of 200, only 4 patients remain above 200 at postoperative day in 2, 3. What about, how did this correlate with weight loss? So the weight loss on average was 4.29 and 4.38 kilos at 30 and 90 days, and only 3% or 3 people, 13% of our population, had returned to their normal weight by day 90. And then I'll show some other data in another talk that sort of mirrors this a little bit, but that's been very common in our experience, is that even up to 3 months, patients are still having a lot of problems with weight loss. I usually see that start to correct maybe around 6 months, and then usually, by a year they've exceeded their weight. They've gone on beyond that. But we did look at how that correlated with testosterone, and it did. So those patients who had a more significant hypogonadism, less than 100, lost more weight versus those who maintained their testosterone. When we looked at complications, our overall 30-day complication rate was 23% for the group, but there was no difference between those who were hypogonadal versus those who were eugonadal. Remember though, most of our patients were hypogonadal, so it's difficult to make these comparisons a little bit. There was no difference in readmission rates or length of stay, even when we broke that down by tertiles of the testosterone levels. What about cachexia? So we utilized the slice-o-matic and psoas diameter on CT scans. What we did was we compared that, their preoperative to their 3-month CT scan, and looked at that. And we broke that again down by tertiles. And although it trended towards significance, we did not see significance in terms of the testosterones for the psoas measurement. So although again we correlated with weight, in terms of that muscle loss, there was a trend, but it was not statistically significant. Some of our limitations, obviously this was a very small trial. We did have some trouble getting all of the labs in all these patients. That was particularly true for LH. I didn't show that continued data of the LH because we had a lot of trouble getting paid for. Interestingly enough, some of these labs, testosterone, we were able to do by standard of care, but some of the others, insurance wouldn't pay for those, and that's why we sort of had to drop off on some of those. But again, we, as being on the eastern border of Kansas, we have patients that travel from a long ways, and so some of those lab draws were difficult for our patients to get. So in conclusion, cystectomy remains a challenging procedure, particularly the post-operative course, and I really feel that we have to look at novel interventions that may improve outcomes. If we're not doing that, I don't know that we're ever going to improve the outcomes associated with this procedure. We know now that hypogonadism appears to be common in men undergoing radical cystectomy, and preliminary data from our trial shows that this persists even up to 90 days in many of these patients. The degree of hypogonadism did correlate with greater weight loss in this patient population, although it did not correlate with cachexia, which was sort of one of our major focuses in terms of this. But it is possible that this treatment or the intervention of correction of hypogonadism in this patient population may represent a potential therapeutic intervention to improve our outcomes in cystectomy patients. So based upon this, we are implementing a phase 1/2 trial for patients who are hypogonadal, where we will be administering testosterone. Obviously, this is only for male patients. And then we will be identifying weight loss. We'll be looking at complications, particularly infectious complications, length of stay, readmission rates, and that's our next step in terms of where we're going from this. We're currently applying for a BCAN grant for that, as well as some internal funding through our institution for that. I do want to acknowledge one of my fellows, Woody Smeltzer, who's going to be joining Vanderbilt next year as one of the oncology fellows. He was sort of the resident who really took this over and owned this trial. We had several clinical study coordinators who were awesome at making sure that the labs got drawn. And of course, thank you to our patients and families as well. Here's a list of our references. Go Chiefs. Thank you.